Yes, good evening, everyone. We welcome you all to OrthoTV online in association with 3M KCI. To introduce today's topic and speaker, I hand over to Deepika Mehta from 3M.
Good evening, everyone. Welcome to the masterclass on negative pressure wound therapy, a game changer. I am Deepika Mehta from 3M and I'll be your host today. Before we get started, I'd like to share some housekeeping information with you all. There would be a live Q&A after the masterclass. To ask a question, you just simply have to type in the question in the chat box, which has been provided in the right side of the screen. We will try and answer as many questions as we can towards the end of the webinar. Right after the masterclass is completed, we'll share a link and the QR code for your feedback on the chat box, YouTube description, comment box on Facebook, and right below the video on OrthoTV website. Please take out a few minutes of yours to share your feedback so that we can improvise on our education and training services. Now, it's my pleasure to introduce our faculty for today. Dr. Vikas Agashe, he's a consultant orthopedic surgeon at PD Hinduja Hospital and Research Center and Dr. Agashe's Maternity and Surgical Nursing Home. He has more than 40 years of surgical experience. He is the past chairman trauma committee and current advisor to the infection committee of Indian Orthopaedic Association. He has been past president and vice president of Bombay Orthopaedic Society as well. He has been faculty at many national and international conferences since, just one sec, since 1999. Our next faculty for today is Dr. R.M. Chandak. He's the consultant orthopedic surgeon at Nagpur. He's the managing director and senior consultant orthopedic surgeon in Chandak Nursing Home since July 1989 and also a postgraduate teacher at Radha Krishna Hospital, Nagpur. He regularly conducts surgical observership programs and workshops, and he has given guest lectures at various national and international forums and has more than 10 publications to his name. Now, moving to the next learning outcomes for basically this particular masterclass. The first learning outcome would be the importance to understand the importance of the negative pressure wound therapy in complex orthopedic wounds such as open fractures, degloving injuries, infected implants, etc. And then to understand the appropriate use of different modalities of negative pressure wound therapy and negative pressure wound therapy with installation using clinical case discussion, and also to understand that optimization is the key to success and overuse key to failure. Now, I'll hand over the session to Dr. Agashe for his presentation. Over to you, sir.
Thank you, Deepika. Can I stop? Can you stop sharing so that I can share? Can you see my screen now? Good evening, all. Can you see my screen?
Yes, sir. It's visible.
Okay. So today we would essentially discuss negative pressure wound therapy in complex scenarios. At the outset, I sincerely thank my orthopedic colleagues as well as plastic surgery friends and infectious disease specialists for helping me in managing such wounds. We all know that any complex wound, the first step is debridement, which actually increases the defect. Very often we have to remove the implant. Then the wound needs to be optimized and we obtain cover or closure of the wound. What is important is somewhere during this time, We have to do reconstructive procedures. And we cannot stop like plastic surgeons at just obtaining wound cover. We have to do reconstructive procedures. And that itself challenges this healed wound very often. And hence, a soft tissue cover which will last, which will not break down, in spite of reconstructive procedures, is the first and most important step in journey towards return of healing and function. So today we will focus on some cases of complex trauma. We will also see some cases where fixation is salvaged, exposed fixation is salvaged, and achieving cover when the bed is suboptimal. These are the three main areas we will focus on. So starting with the first case, this was a middle-aged person who presented about 2.5 to 3 weeks after a road traffic accident with right tibia segmental fracture, grade 3. Wound was extremely foul-smelling, and he was advised amputation elsewhere, and that's why he presented to us. You can see it's a segmental fracture tibia. This is how he was managed initially, and he had a deep infection when he presented. Just basic cleaning, this was the wound. We realized that the fracture was grossly unstable. His posterior tibial was well felt, but dorsalis pedis was not well felt. So essentially it was a vascular limb, though badly infected and grossly unstable. The idea, of course, was to salvage that limb. The culture which we took on day 1 showed resistant strain of gram-negative, Enterobacter cloacae, which was a resistant strain. And then the ID people started metrogel and colistin. He started developing temperature. So we explored, and now you can see the wound has started improving. That's after external fixation and debridement. The upper or proximal fragment did have some posterior attachment. So we thought we should be able to salvage this portion. With negative pressure therapy, you can see the wounds have started improving. And then we decided to have a flap cover for proximal defect, for the proximal wound, because it was, the bone was attached to with the soft tissues. So a rotation flap was done by the plastic surgeon. And here you can see the flap cover obtained. The distal portion was loose. So obviously we excised it. So after excising the infected bone, you can see that again, we continued with negative pressure therapy and the wound has improved significantly. We needed some support, so we did a fibula fixation and we did a split thickness graft basically to tide over crisis, and we achieved a decent cover. Question is it the destination? Very often the plastic surgeon would say, now you have got good skin cover. No, we have to obtain fracture healing in a reasonable position. That's our aim. So first step again, or next step, is achieving a good soft tissue cover, not just a split thickness graft, but a flap. And that is what we did. Here you can see after doing a cross-leg flap. There was some bone formation in the middle, and you can see the proximal fragment is reasonably big now, which has survived, and the distal fragment is quite small. Obviously, there were many options. One could use a ring fixator, one could use an internal fixation. Now, since the patient has had external fixator for a long time, we decided to put MIPO, and a distal tibia medial side plate was done. Unfortunately, the plate had to be removed because he developed very severe infection. Within 12 days, we had to take out the plate. So it was a severe setback. Again, we go back. We need to control the infection. We need to optimize the wound, and we need to reconstruct. So debridement, culture-specific antibiotics. Now again, negative pressure therapy came to our rescue. You can see the wound is not very good, but started filling up very well with negative pressure therapy. And at this point, you can see after about 2 weeks, we have a very good wound. And therefore, that big defect, bone defect, was covered with a local flap, and the remaining areas were covered either by split thickness or cover or closure. So again, we have a decent wound, but we are back to second square of a good, decent soft tissue cover, but not a very good fixation. So then, since the envelope was very good, we did refixation with, we rather did tibialization of the fibula, bone grafting and Elizoro fixator, and this is him with consolidation, reasonably straight limb, some absolutely consolidated tibia profibula grafting, and an excellent, excellent range of movement and appearance. So here, negative pressure therapy was a major contribution in salvage of this wound, because you can see he presented like this. That's a huge defect we created. Wound filled up with negative pressure therapy. We could do a temporary cover followed by a proper soft tissue cover using a flap. We did MIPO, which unfortunately got infected. Plate removal was done with debridement. Again, here, negative pressure therapy helped us, and we could achieve cover. And this is him at absolute healing. So, friends, in such complex wounds, negative pressure therapy helps tremendously. However, one has to remember that that is not the end of it. Very aggressive debridement is the most important thing, and of course, aided by appropriate antibiotics, appropriate support, and management of comorbidities. Thank you, friends. If there are any questions, you can put on chat box, and meanwhile, I'll ask Dr. Chandak to share his screen.
Yeah. Thank you very much, sir. It is always a pleasure and honor to listen to Dr. Agashe, sir, on his infection and such difficult cases. So I'll be presenting negative pressure wound therapy in complex open injuries and some degloving injuries. I hope my screen is visible, sir.
No,
Yes,
I can't.
Screen is visible, Deepika?
Yes, sir. It's visible.
Okay, fine. So when such a compound tibia comes and initially wound cannot be covered completely after fixation, V.A.C becomes a game changer. Let us see some examples. So this was a complex trauma presented after some time, had initial 3 or 4 debridements, and how to manage such wounds is difficult. In previous era, we used to debride, and then the wounds used to get contaminated with pseudomonas, and that took long time in wards to manage such wounds. However, the advent of V.A.C after thorough debridement and few negative pressure wound therapy has changed the management of such difficult cases. So let us say, take this example. When wounds are badly infected, V.A.C really is a boon. This is how the patient came to the hospital, pouring pus, had already renal failure because of severe sepsis. Hemoglobin was only 4.5, and patient was in a bad shape. So after initial management in ICU and resuscitation, this initially was managed at another facility and then was transported to our center. So this was the picture after first days of wash and lavage. And when the things settled down, it was taken up for a debridement, and the initial primary negative pressure wound therapy after first debridement was started. And immediately within a day or two, his renal function started improving, and hemoglobin after a couple of transfusions, patient got settled. This is after the negative pressure wound therapy. And we can see from a previous wound, now the wound edges are healthy. The granulation is picking up. Good vascularity is there at wound. However, bone has a defect. This dramatically changed the outlook for this patient, and further negative pressure wound therapy brought out all the things which we wanted. The wound was settling, the plastic surgeons were now happy to provide cover. So this was after negative pressure wound therapy. And in such bad wounds, initially we would change the foam 2 or 3 days and then change it. But as the wound settles down, we may keep it a bit more longer as well. So after the adequate bone debridement, the bone gap was almost 6 inches. So this was just before the flap. And as you can see, there was a large bone flap, a bone loss, and this would have required a large flap. So to avoid a large flap, initially it was done with a split thickening graft, and afterwards with a cross leg flap as the wound was quite large. And then ultimately the cross leg flap took very well, and there was a cement spacer in the void so that we have a large space for putting bone graft. This is at this time the X-fix was changed to a ring fixator with an antibiotic bone cement block as a spacer. And after 6 weeks, once the spacer was removed, there was a good induction membrane which would have facilitated good graft take-up. And this graft, this space of almost 6 inches was filled up with the reamer, irrigator, aspirator obtained graft. These are the Rhea bone graft packed into the cavity. This is the sludge of Rhea graft packed at that cavity. And this is on immediately after the Rhea grafting. This is how the column of bone looks like. And this is after in the consolidation phase. And since this graft take long time to consolidate, he was protected with a subcutaneous plate. And this is the final result. The coyness was minimum and patient healed well. Another complex case of trauma had a road traffic accident 6 months back, had an initial management in a X-fix, then was shifted to Elizaro, had some flap rotation which also gave way, and the bone now is exposed. This needed radical debridement of the dead fragment, and after the debridement, whatever residual tissue was there, that had very weak pink, not a very pink tissue. So to improve vascularity, a negative pressure wound therapy was given, and then was managed by radical debridement and flap cover. And after the flap cover and LRS fixation, along with beads to take care of the residual infection, he was again managed with Rhea bone graft, and LRS was continued, and the patient healed wonderfully. So for bone compound fractures, bone with large bone loss and initial wounds, V.A.C and negative pressure wound therapy are really a boon to manage such case. Now look at this case, was a crush injury. The foot and leg and ankle came beneath the tire of a truck with all grease and mud. So radiological almost severing of the foot. Our surgical aims in this patient is to debride, of course, along with IV antibiotic therapy. And then once the foot stabilization is provided, then we aim towards good tissue optimization. So this was thoroughly debrided. All the dead tissue, etc., was removed. Then hydrodebridement was instituted. So in the hydrodebridement, so this is how the hydrodebridement machine works. So the layer by layer tissues, the right hand side is not of this case, the left hand side is of this case. So this is how the debridement was done, and then wash, lavage, etc. continued. So the most important thing in this reconstructions and before application of negative pressure wound therapy is a good debridement, so that all the dead tissue is removed, and then the V.A.C serves in improving the vascularity of that wound, takes away all the tissue edema, decreases the bacterial load, and then this patient was managed with foot cover with negative pressure wound therapy. And once everything settled down, the plastic surgeons were ready to flap it. Then a microvascular flap was given, and this was rested on a foam support to avoid heel pressure sore. And then patient had a optimum tissue healing, giving a good return to function at around 6 months down the line. And of course, his foot was shortened as the bones were severed along, and then this healed very well. At this point, I would again hand over to Dr. Agashe sir, and then after that, I'll be taking over vacuum assisted closure mode of negative pressure wound therapy, which is quite useful when we want to reduce the depth of wound or we want to have a closure with successive wound therapies. Agashe sir, can you take over?
Yes. Yes. If there are any questions, we will take. Can you just elaborate on the hydrotherapy for a minute?
So basically, hydrotherapy is um, basically a machine-driven. What it does is there is a jet of water which also has a vacuum suction. So all the debris, which is a dead tissue, a very fine layer of debris is removed by this machine. So it is debridement. Of course, before that is definite our sharp debridement with scissors. And once wound is debrided, we can institute the hydro debridement so that the fine layer, mud, grease, etc., everything is removed. And then we go ahead with the V.A.C or a negative pressure wound therapy when a hemostasis is completely achieved. That helps in removing a fine layer of mud, etc., which is impregnated on the wound and is a useful procedure, but of course not required in every case, only in those.
Thank you very much. Thank you very much, Dr. Chandak. Can you see my screen now?
Yes, sir, we can see.
And I'm audible also?
Yes, sir.
Okay. So let's go ahead. If reconstructive procedures have to be done underneath the cover optic, that becomes more challenging. For example, this patient, a young patient presented with infected pressure sore over patella. You can see this, the patella, which is almost necrotic, and the quadriceps mechanism is has almost disappeared with a large wound. So this is a large defect with infection, rupture of quadriceps, necrotic patella, and the culture was MRSA. So question is, why did this happen? So this was a young girl who was short statured, walker dependent, and she presented almost 10 years ago. She had an RTA at the age of 10 years, had bilateral open fracture tibia fibula, had underwent multiple surgical procedures, was unable to bear weight on the right leg. And when she presented, you can see the tibia is in non-union, is in varus and recurvatum, and both the sides, there is a very poor soft tissue envelope. Question is, can we do something by which the fracture would heal in a decent position and she starts walking? So the first step, of course, is achieving good soft tissue cover. Now, local rotation flaps or cloth leg flaps were out of question because of the soft tissue envelopes on both sides. The next thought process is, can we manage with a microvascular flap? Unfortunately, she had a single vessel. The entire limb was served by collateral from peroneal arteries only, and therefore microvascular was out. So the only was done, across thigh flap was done. The leg had to be kept under significant flexion at the knee. Otherwise, the flap could not cover the leg. I applied external fixator to stabilize both the legs. The plastic surgeon informed me she had a small sore, but she insisted on going home, which was almost 1,200 kilometers from our place. And back she comes 4 months down the line with infected pressure sore over patella with torn quadriceps and bad infection. This happened because there was a scarred skin over the knee, which was not a good skin envelope. And therefore, it just gave way. Now, we have a skin defect, we have infection, we have ruptured quadriceps, and we have necrotic or osteomyelitic patella. Can we salvage this? Yes, the game changer was there. Of course, good debridement is absolutely essential. We, of course, had to manage her non-union, mal-positioned non-union. So, this is where we are. And the final goal was long ago, over. So she was obviously keen on having a mobile knee. So the idea was first improve the wound, use negative pressure therapy. After the wound improves, we thought that we will mobilize and repair the quadriceps and use a flap cover and later address the primary problem. So this is after very aggressive debridement and serial negative pressure therapy. You can see the defect has almost, the bone is almost covered and the defect is absolutely clean. So that was the time when we decided to do a reconstructive procedure for quadriceps mechanism and covering the knee. You need to have a decent cover on the knee, then only you will be able to get some movements of the knee. So a medially based flap was marked, raised to expose the torn quadriceps. You can see the flap is raised. The quadriceps mechanism is seen there. That's the torn quadriceps mechanism. So after appropriate debridement, we took out pull-out sutures through the quadriceps, through the patella, and then the plastic surgeon rotated that flap to obtain cover and knee. So this is at presentation. This is at 3 weeks where with quadriceps reconstruction, flap was done. And this is at 14 weeks, which was reasonably good. Now, as I said, so the flap also is often challenged. This is exactly what happened. She sustained a fracture lower end femur. So we had to go through the flap and fix the femur. So we had to raise the flap again. Now you'll realize that our primary aim is still away. We have to address her tibia. So that's mobile unaffected knee. But we decided to address the tibia. That we could do because of the cross thigh flap. And we did a retrograde humerus nail for a retrograde calcaneotibial fixation and correction of malunion, supported with plate and bone grafting. So initially she had significant calcaneus and a non-union. Now you can see the limb is reasonably good. That's how she presented. That's how she had large wound on the knee. That is how after debridement and negative pressure, the wound improved significantly. So we could do a flap. That was it. After about 2 years, the flap was challenged because of fracture lower end femur, which we addressed with plating. Then we decided to address the the non-union of tibia with recurvatum. And this is how she is with a plantigrade foot, with a decent angulation, decent alignment and healing with a decent knee movement. Thank you, friends. So I stop sharing at this stage so that Dr. Chandak will show the next case. If there are any questions, I'm happy to answer.
Deepika, any questions so far? If they are there, we would answer those questions, or Kavita who is taking. Sir, if I ask,
yes, please.
How much is your VAC pressure usually in these cases?
So the ideal pressure is minus 125. Generally, I try to keep at 125. However, during first debridement, very often the bleeding is significant. The entire tissue is very, very hypervascular and the bleeding can be significant. So in that case, either I use lesser pressure of about minus 75, and there's no objective proof for this. This is just by trial and error. I realized that the granulation tissue formation is little suboptimal, but at least I have a good enclosed sealed wound and I don't have excessive bleeding.
Yes, thank you, sir.
What is your experience?
Same. So on day of a compound fracture being put on a negative pressure wound therapy, so initially we keep a wound pressure quite low, and in the setting we make it as a mild at the machine setting, so that there is no hemorrhage, because occasionally we face that problem when suddenly the gush of blood may fill up in the canister, and that is what is not desired. So to prevent that complication of hemorrhage in a canister, we have to avoid take a low pressure initially. What I found is when infections are there in dirty wounds and when that requires higher pressure because the exudates are a bit more thickish. So we have to have more pressure in those things. There we use 125 as you suggested.
Right. So second time onwards, I usually make it 125, but occasionally day one, I might put 75.
Yes.
Yeah.
Perfect.
Okay. Yeah. I think you can go ahead.
Yeah. So able to see the screen, sir?
I don't think so.
I'll share again.
Yeah. Right.
Yeah, able to see now.
Yes.
So now here, what I would be elaborating is use of V.A.C in certain fractures, open fractures, and the use of V.A.C as a negative pressure closure mode or the V.A.C mode, or we call it as a V.A.C mode, vacuum assisted closure mode. So some tips and tricks I'll be sharing. So this was a patient who had infection, and if we leave the wound widely open apart and then put a negative pressure wound therapy, the wound edges retract, and then those edges are then difficult to cover, or then we have to substitute a V.A.C or a flap cover. And even after acute compound fractures of leg, when there is a triangular flap, we don't intend to completely tightly close it. And if we leave them and put a negative pressure wound therapy, then again the skin edges retract and then closure becomes difficult. So on that time, we put a something like this closure. At the center we close and at the edge we keep it open so that wounds can be closed. So this is what I usually would like to do. A compound fracture, both bone leg, the spike of bone is out and has made a skin rent. So this is debrided and V.A.C applied. In our theater, we call it as a moustache foam. So there is a foam sheet here, and then at the end it is there, which we can take it out. So a lot of negative pressure is put on this foam so that every blood, etc. is taken away. The biggest advantage we find is then very rarely we are required to go for a flap. Of course, if there is a tissue gap, we'll have to go for a flap, but we are able to manage without a flap. And secondly, the tissue edema reduces very rapidly. We have to just take care of hemorrhage in acute setting. So adhesive film is applied in the adjoining area so that there is no soddening. Then a vacuum assisted closure mode. So we put a small foam inside, and then on that we put a foam sheet, and on that we apply a sensor track. So it is sealed now with a sensor track. Then we make a small hole into this foam sheet after adhesive sealing is done. And then we apply suction with a tube from the suction tube so that immediately the whole adhesive film sticks very nicely after removing the layer 2. And this is how the things progresses. And so the thing is, we have to make a seal which is impervious, so it doesn't leak. So initially a lot of blood etc oozes out from the edges. So as soon as we put a suction tube and we suck it out, the blood is drawn towards the central part, and then we apply the sensor track. That is what they call as therapeutic regulated acute care. And I find this sensor track to be very nice. It sticks very fast. It has a circular sheet. We remove that adhesive film and just paste it and connect the tubing, and then put the pressure on 25 or 50 or 75 initially. And then in the next day round, when there is not much of collection in the jar, then we can increase the pressure. And then we see the seal check. It should be optimum. It should be in the green zone. If it is leak is detected, then we have to improvise on the leaking or the adhesive film barrier. So how much pressure to keep? And this I found literature in an uncompressed state, there is 95% void volume. In a fully compressed state, 80% void volume. Even after that, the capillary action continues. So optimum is around 125. And coming to use of V.A.C after the infections, after open reduction and internal fixation. Just a point here. Many times we see a sort of froth in the canister jar. This is nothing to be worried about. Many times we see that. So this patient, unfortunately, after his side sweep injury, coming to use of V.A.C in a compound fracture after infection is set in, after open reduction, etc. So he had a side sweep injury and was at a center managed, at another orthopedic center was managed by a joint replacement procedure. And as we would have thought, severe infection and exposed implants was the result. So this did not respond to weeks of antibiotics and severe infection persisted. So we removed the implants, debrided. After one dressing, as you can see here, the infection settles down fast. Good amount of granulation tissue is created. Tissue edema goes down. So all the telltale advantages of a negative pressure wound therapy. And this stability was provided to a dangling elbow in an ingenious way by a titanium elastic nail in the cavity of humerus, in the cavity of ulna, and then negative pressure wound therapy. The whole picture changes dramatically and it gives a good function. This was done with a titanium elastic nail. How to insert that is shown in the pictures. We have to make a L bend. So 2 heavy duty pliers are needed for that. This is the trick of insertion. So at times I avoid a X fix. Of course, if it is mandatory, we would use a X fix that was bent. And then this is how it looks under elastic recoil. And you'll see after second V.A.C, the wound settled down. And even we were able to have a secondary closure. So this was secondarily closed. This is X-ray picture after 3 months. So complete bending of the elbow and flexion was there. This is the amount of movement permitted by the elastic nail. And this is enough stability with the tissues, and he was happy. Sometime during the time after healing, this elastic nail would break and then we can take it out if it juts out. Coming to use of V.A.C in routine compound fractures. So this is a compound fracture reported within 24 hours. So of course we would debride, make the wound comfortable, remove all necrotic tissue. And at this point of time, plastic surgeon always would like to wait for a couple of days. So the zone of injury is well defined. They would not put a cover immediately. And that is where V.A.C helps us. So we make a adhesive barrier negative pressure wound therapy, occlusive dressing, we check it, and after application of sensor track. And then this wound was comfortable as the muscle bed was there with a split thickness graft. And this was the final tissue healing. Now, of course, his tibia after a nailing procedure also healed well. So when there is compound fracture and there are multiple wounds adjoining the compound area, then it is a bit tricky to seal those wounds. So these are 2 wounds connected by 1 sensor track. Of course, when the patient can afford and we can use 2 sensor tracks, that is always advisable. But if it is not available and for a poor patient, I may use this trick of having a conduit over a skin which is pasted with a adhesive film so that there is no soidening in the central area. And this is also adjoining small wound which is connected with the sensor tract and a bridge of foam, but of course sealed with a occlusive dressing. This is additional foam. This 2 sides can be managed in this fashion if required. And that is a conduit channel and that provides adequate negative pressure. This is vacuum assisted closure mode. So how do we proceed? This was a patient had a fixation at another center and he came with exposed implants and all these tissues inside kept on oozing and discharging lot of pus. So that was implant was removed. As you can see, the whole area has to be exposed. Remove all dead tissue, all dead muscles, even the compartment syndrome muscles which develop in such a situation. So those bellies were removed. As you can see here, it is all pale. Tissues are not looking good. Debrided, wash given, and then I would treat sometimes with the extracutaneous plate or a X-fix, whatever is the choice. This is extracutaneous plate as a X-fix, and the whole implants were removed. Negative pressure wound therapy. This is lateral infected LCP was removed and a ECPO, we call it as supracutaneous plate or extracutaneous plate. And to get closure, this trick we do. So keep the skin coapted. At places, keep the foam inside and coapt the skin, so that rather than the skin edges retracting, the skin edges are coapted. And once they are coapted, they can go for a secondary closure. As in this case, we were able to have a secondary closure. So this is one of the boon which we have with vacuum assisted closure modality when we use negative pressure wound therapy. This is another case. A badly infected patient had an initial compound injury and also had other comorbid injuries during his initial accident. As you can see here, this was a ghastly sight. Pouring pus, his enders jetting out from knee and badly infected. So enders backing out. So this was all debrided, and you can see the whole bone which had come out in the initial accident was ivory white. So we have to remove that bone, and then vacuum initial complete exposed method, vacuum assisted closure in the second sitting, and then the wound heals. This is another way of lacing, as is known as, where you want to bring the wound edges together. So you can use the staples, and then inside that you can use ethylone #1 and then coapt the skin. You can go on tightening inside, and 1 or 2 dressings, usually wound would be able to close secondarily. Or if a good flap is available, plastic surgeon would be willing to do a flap as well. We have to decide what the wound takes and what is good for the wound and tissue healing. In that case, a complete dead excision of bone was done, and then the wound settled down. So what was initially pouring pus, by the end of around 20 days, looked good. You can see the tissue healing, which is quite nice now. And this is how the wound healed. A wound which was pouring pus just because of the boon of negative pressure wound therapy, we were able to have a nice wound healing. Definitely V.A.C is a game changer with following assets which we get. It reduces the number of dressings and trauma to the patient, good tissue healing, draining excess fluid from the wound, and the overall limb edema goes down. The bacterial count is suggested to be decreasing in the wound, keeps the wound moist, and helps draw together wound edges. To me, these are great assets of V.A.C. V.A.C improves granulation tremendously. So much so, many times, that immediately after the V.A.C, the first negative pressure wound therapy removal, the plastic surgeons are happy. In previous era, if you go back 20 years back, they used to advise every time they see the wound, used to say that the V.A.C, the granulation is still quite pale. We would wait for some more time, and it took long time. But now, with the advent of negative pressure wound therapy, we are able to get a good vacuum. Thank you very much. I'll hand over to Agashe sir now, and would have some questions if they are in the question.
Yes. Thanks a lot, Dr. Chandak, for a phenomenal presentation. My question is, how do you manage with either extracutaneous plate or an external fixator? How do you achieve sealed wound?
Yeah.
Because very often it starts leaking. The negative pressure is not, you're not able to obtain negative pressure.
Right. So if the best thing is, if the pins are coming in between the V.A.C area, either we can shift to adjoining areas. But if that is not possible, a pin inside the V.A.C also is a possibility. What we have to use is those stoma closing creams are there. So we put a film first, and around the pin, we put that stoma closing solutions. They provide a bed on which the film paste. And couple of times I was required to take the cell from the company persons who helped me out initially, and then all our OT technicians learned that art, and now that is not a big issue, and we are able to do it now.
So you mean colostomy solutions?
Colostomy solutions.
That is used for colostomy. Correct.
Yeah.
This is a very important point, friends, because very often with fixators, it becomes very difficult to have a good sealed wound. So this is a really useful trick.
Yes.
Thank you, Dr. Chandak. Let's move ahead. And very often, there's a significant infection in presence of fixation modalities or bone grafts. And if you have to take out everything, then you go back many months. So let's discuss one case. This was a middle-aged person who presented with infection and exposed plate. You can see this plate is exposed. That's the plate, that's a wound which has not healed. You can see several things are done here. And that's a medial tibia plate, and that's the possibly fibula. So tracing the history, almost 16 years prior to his presentation to us, he had some trauma, was treated with bone grafting. He developed infection almost immediately. And next many years, he was being treated. Debridement was done in 2015, but the ulcer persisted. And one look at this ulcer, and anybody can make out that this is something sinister. And that is exactly what was. He presented to an orthopedic surgeon who referred him to a cancer specialist, orthopedic oncologist, and he did an age biopsy and turned out to be squamous cell carcinoma. This is the X-ray. You can see highly suggestive of a malignant lesion. The PET also was suggestive of malignant lesion, and that's the PET report. He had multiple lymph nodes also, and the plastic surgeon, the oncologist, excised the lesion en masse, and then he plated the tibia. Unfortunately, he got infected. He removed the plate and did multiple cement spacers. And after some time, he used a live fibula graft and plated the tibia, covered that with a gastrocnemius flap. Unfortunately, he got infected. The negative pressure was used to proximal portion of the flap, only where there was a skin defect. And unfortunately, the infection persisted, and he presented to us at 8 weeks. So here you can see that's when he presented. He had some varus of the proximal end, but that's not really important. What is important is the wound, which is badly infected, and can we salvage his plate as well as the implant and the flap, of course. Should we do any more investigations like MRI? Not really, because the treatment here, whatever it may be, is exploration, addressing the implant as well as bone grafts based on what you find inside and try and cover it. So this is where you are. We decided to, that's the gastrocnemius flap. So flap coming from this side. So we decided to take this incision. The skin was really bad all over here. And here you can see that's the skin which was bad. That is the excision of the skin done. Then the incision was continued like this. You can see that's the gastroc flap which was raised, and the proximal portion of the plate is exposed. You can see multiple areas of dirty granulation tissue. Now this is the image in lying down position, turn 90 degrees. That's the infected area. The flap had infection underneath. There was infected area here. So all in all, the entire surgical site was infected. No doubt we had to take out the plate. Question is, can we salvage fibula? But it goes back to so many things like excision of the entire fibula, segment transport in a patient who has been suffering for almost many years. So this is after plate removal. You can see there are multiple areas of dirty granulation tissue. But after decent debridement, you can see the wound is reasonably all right. And we were really getting tempted to salvage the fibula. This is after negative pressure therapy. You can see the wound has really improved. And this is where you are. We have a fibula Obviously, X-ray will not tell us whether it is infected or not, but we were very, very keen on salvaging that, because you can see after good debridement and negative pressure therapy, this part of the fibula, though it is exposed, partly it appears vascular. And at this point of time, there was hardly any infection. The wound appeared very, very clean. And therefore, we covered the flap, covered the wound with the old flap, and that's the defect. You can see there's a big defect in the middle and fibula is exposed. Now, how do we address that? We will need another flap to address that. Or can we use negative pressure therapy to improve the wound? So we used negative pressure therapy, and within no time, you can see the fibula was completely covered. It was a vascular fibula, intact fibula, uninfected fibula, and using negative pressure therapy, not only the wound improved, but we could cover the fibula. So this is the wound at about 7 months. Unfortunately, this live fibula, being a large, long, unsupported fragment, broke. If you read the literature, you will realize that almost every patient of live fibula fractures. But good thing is, as they fracture, they hypertrophy. The fibula hypertrophies with fracture. So don't worry about this. Give a walking brace. You can see the fibula has started hypertrophying. This is at 7 months, he is walking with a stick and caliper. This is 14 months. Still more hypertrophy, but not really. You're not really happy with this hypertrophy. And then he had a fracture. He had a fracture. He presented at 20 months in August 2020. Because of Corona, he could not come in between. Remember, they usually don't have adequate nerve supply. So they don't get much pain, but they just fracture. Here you can see the fracture has already occurred, but he has started hypertrophying. This is at 20 months. And this is at 27 months. You can see the wounds have healed extremely well. He has an excellent knee function, and that's the X-ray. He does have virus, but he has an extremely hypertrophied, back to normal tibia. And from here, this was the badly infected area. We had to take out the plate, but we could salvage the tibia. I cannot imagine what would happen without salvaging that fibula, because again, we would have to address almost 2.5 inches or 5 to 6 centimeters of defect in presence of skin defect or soft tissue defect. So here, after removal of the plate, this is after a couple of negative pressure therapies. This is after another 2 negative pressure therapies. You can see the fibula completely covered, and this is the skin which is absolutely covered. That's the fixation. That is the salvage of trying to salvage the fibula. This is with stress fracture. This is with another stress fracture, and this is the final result. Completely hypertrophied fibula, and the stabilization was gained by salvaging that live fibula to a large extent because of negative pressure therapy. Of course, as I said, good debridement, appropriate antibiotics play a very, very major role. Thank you, friends. Dr. Chandak, open for discussion. I can't hear you.
Excellent case, sir. That was such a lovely thing to see a live fibula transplanted and hypertrophic to almost the original girth of tibia. Nowadays, we come across less and less of this sort of work, but excellent. That was fantastic. And complete wound healing without a sinus, without infection. That was lovely.
Thank you. Thank you. Shall we go ahead with your cases now?
Yeah, I'll share my screen.
Yes. Thank you. Thank you.
So I'll be presenting some useful applications of VAC. I hope the screen is visible to everyone. So chronic wounds and negative pressure wound therapy. they act as a healing enhancer. The secondary raw area with pockets and discharge and scarred epithelializing edges, they are all removed, debrided, and then a negative pressure wound therapy is instituted so that whatever pale looking granulation is there, that is taken care of and then covered with a meshed thickness graft. And good take of graft is what we would observe in such situations. So these wounds are difficult to heal. Venous ulcers with a lot of scarred bed. So this was a patient referred from our side to my plastic surgeon, and he managed that case. And at that time, negative pressure wound therapy had just come, and he, with pleasure, sent me the images that the wound now looks quite good. Of course, apart from elevation and every other thing for a venous stasis we had to do, and that wound was ready for graft, and tremendous amount from a granulation which was very poor to a granulation of this sort, and which takes up. Otherwise, usually the experience was this split thickness graft used to get rejected, or the wound continued to discharge and remains similar. And patient used to live with these wounds for long time. Of course, he is going to require further care and elevation, etc., everything. But we were happy with the split graft alone, and that healed wonderfully. Such wounds which have stopped progressing further healing, we do not see the advancing edge of wound healing millimeter by millimeter. And in such wounds, whenever we face such a situation, good solution is to use a negative pressure wound therapy. And then once the bed is quite vascular, the edema goes away, the scar tissue declines, and then we do split graft and they heal well. And even after application of a split graft, negative pressure wound therapy allows us to paste the graft quite effectively, and the stable take of the graft is there. So this is my own case where we did a split thickness graft for a large degloving wound. And in the first dressing, we are not very happy with this lot of amount of exudates which are coming out and seeping through the graft tissue. And then we applied a negative pressure wound therapy. Not only the wound healed well, the take-up was also good, and our worry of infection also declined. So that was a good use of negative pressure wound therapy in such wounds. When we have a large degloving wound and we apply large amount of foam, it is always good to use staples or quilting in the center part so that foam is well retained and we don't lose the foam from the edges. So whatever the area comes in contact with foam, granulates very nicely is what the observation is. It's not only the negative pressure, it is the lattices of foam which leads to development of good granulation. That is very useful. Negative pressure wound therapy can also be used along with beads for high elution of antibiotic. But in this situation, we would use an intermittent mode of V.A.C machine. After compartment syndrome, this is another very good use of negative pressure wound therapy. Once we release the compartments and that large amount of area, we would cover up with a V.A.C as a first dressing, and as everything settles down, then a split thickness graft and a good mesh graft gives a large area coverage. So that can be very easy. Some complications can ensue, as in this external fixator patient, when the pressure we used was 50, large amount of blood collected inside the adhesive film. And this we required to revise. And what we saw was one or two bleeders which kept on, rather actually veins which kept on oozing inside, and that required a complete. And whenever this happens, you would always otherwise also get a coagulation profile done and then reseal the wound with a low pressure. And that was revised, and then we had a good healing. Some V.A.C where the pins are inside, as sir said, they are in the center of the wound which is not progressing well, dead tissues, etc. And we have to revise the X-fix, take it out of the situation, and then revise. If the pins are inside, then we have to use the colostomy solutions to take care of the pin. But if we are able to take the pins away from the zone of injury or on the other side of zone of injury, that is always better. And then that is what I like. I would like to take the LRS on the opposite side of the major wound. And many of these patients have a heel area which is quite sensitive. So keeping them on a heel cushion is a very nice idea to avoid that small pressure. Everything else then heals up, but then that small wound on the heel keeps on continuing and bothering him for a long time. So this is a useful tip. This is an example of a patient who had a road traffic accident, initially a closed wound, and then patient was operated. Distal femur fixation was done with a plate, and fifth, sixth day he developed a lot of fever, discharge, etc. And this is how then the patient was referred for a severe infection and septicemia, etc. So the plate was exposed, joint cartilage you can see in the wound. As you can see here, it's the joint cartilage. So acute debridement, thorough wash, lavage, all necrotic tissue removed, all the skin edges which were dead, they were removed. This was opened and debrided. Adequate size foam utilized in the wound packing. This is how we pack the wound. So it has to be exactly catering to the size of the wound, and then adhesive draping is done. You need assistance at this time so that you can appropriately put the foam inside. This is after the first vac therapy. This is after the second vacuum dressing. And as you can see here, the wound is now stabilized. This is the subsequent picture. This is after just before the flap. We have retained the implant as they were stable enough. Flap cover was given, and this vac after the first healing, the tissue healed very nicely. No discharge. Patient was happy as well as the surgeons. They were all happy, and a good tissue healing in long term with the retained implant. Of course, he had a lot of knee stiffness, etc., for which he required subsequent procedures. VAC can also be used as a surface VAC. So many times when we have large wounds or patient is obese and a lot of fat subcutaneous tissue is there. So in this patient, we did not put foam inside the tissues. We just applied a strip of foam onto the tissues, and then that later. So initial wound was not good. And then after the application of surface VAC, that improved and had a lot of fatty tissue in the connecting canister. So this was a patient who healed very nicely after application of surface VAC. Surface VAC is nowadays a thing for many complex wound scenario like revision knees or for fracture calcaneus fixation where a lot of tissue edema, etc. has developed. What it does is sucks away all the tissue edema from the subcutaneous plane. But of course, you get some amount of tissue soddening at the edges of skin, which you have to take care by early applications of VAC revision. For large degloving wound is another VAC tremendous use. So you excise the dead tissues, the flap, whatever is surviving, and then you reposition it, and then put a negative pressure wound therapy after thorough hemostasis and wash lavage. These large run-over wounds, otherwise they will keep on exudating within 24 hours. The whole dressing becomes soaked. Was very messy to manage such wounds, which now we can debride and then put under negative pressure wound therapy, and they heal appropriately. What you need is a large. So in addition with the film supplied with the foam, we may use a large IOBAN film sort of thing to completely cover. We just take care that circumferential adhesive film should not be constricting, and they should give a good vacuum seal. And this is how a large degloving wound can be saved without pressure onto the limb so that the whole tissue edema is taken away. One case I'll show of VAC even in chronic infection. So this was a simple grade 1 neck femur, nicely fixed, but had bad infection, had 2 curettages prior, were not effective. And then the first surgeon had beads inside the wound. Even then, a lot of soakage came out that did not heal. So they tried packing with wound gauges, gauge and everything. Still, it did not heal. This was the picture of the implant removal. Still, the wound continued to discharge. What is required in this situation is not a mini approach, a complete debridement of all the necrotic deep tissue. So this was washed, lavage, and then you extend the wound, debride all dead tissue, remove all the fascia, etc., which is not live. And then after vacuum assisted closure mode, that patient healed well. During the course of treatment, this was a picture on one day. So here the foam had stopped breathing. It was not expanding. So this was the time to change. This is one of our clue clinically, that foam many times, for want of patients' consent, etc., for getting them next foam supplies. So if it is extended beyond 3, 4, 5 days, and if the foam is not breathing, if it is the tubings are getting connected, this is the time to change. So what we do is disconnect and see whether the foam is breathing, expanding or not. If it is not, that is the time. And when you see soakage inside, either you increase the pressure, debride the wound again, and change the dressing. And this is after debridement. And VAC picture, it totally changed, and we had a good tissue healing. So this is where the foam is not. You can see here, as you have removed the pressure, but still the foam is in a contracted shape. So this is surely needs a change. And then finally healed, and we had good healing. For such wounds, many times this used to happen on plates on tibia. So apply a negative pressure wound therapy. If the implant is stable, keep it in situ. And once everything is okay, then flap cover would provided, and then the implants can be kept in situ. If the wounds are there on leg, foot, we like to call this as a samosa sealing. So into difficult areas of sealing, so we seal it by 2 films, one dorsum, one ventral, and then we seal along with the toes, especially the wounds are near the forefoot, and keep a pressure low. Do not have entire circumferentially tight loops, and then the whole things would be sucked out. And when the things are comfortable, then we can go for the further plastic surgical procedure. At this point of time, I would stop here and then hand over the mic to Agashe sir, and for his comments as well.
Thank you, Dr. Chandak. It was very, very important to note that implants can be salvaged. And we are always concerned that after osteosynthesis, if there is infection and the implants get exposed, we are always worried that if we are not able to salvage the implant, you go back several months, because then you will have to do a fixator, you will have to do a skin cover, so on and so forth. So with this approach, only thing is you need to address early. You can't wait for a couple of months and keep doing dressing. You need to address real almost immediately. As soon as you realize that it is infected, the implant is likely to get exposed, you must do aggressive debridement, negative pressure therapy, followed by a flap cover. That is very, very important. Any other important point, Dr. Chandak, you would like to mention?
And as you said rightly, those implants which are correctly fixed, holding well, providing good adequate stability, I think those are the ones we would definitely like to salvage. And the way to go is to go early. That is, as you said, perfect.
Yes.
Well
Most
said.
important is go early. Now, coming to types of negative pressure therapy.
Yes, very important topics.
Initially, for many years, we used to use what is called standard negative pressure therapy or standard V.A.C. Now, then people realized that possibly we will be able to decrease the infection using mechanical means. So can we irrigate and suck? Yes, for many, many years we have done that, but that used to help to some extent. But on the other hand, because you will not allow the liquid to remain on the wound, and it reaches only superficial wound areas. But if you soak the part, then the liquid would go in deeper layers. It will remain in contact with the wound before it is being drained, and then you can apply vacuum to suck it out. So it will reach deeper wound areas. And then, therefore, the concept of instill negative pressure therapy or instill V.A.C came in. So it consists of instillation of some topical antimicrobial or saline or antiseptic material for some time and then take it out. several questions arise as to which material you use, how do you use, is there a separate foam? And I'll try and address that in next few minutes. So you can see the most of the machines are changed to this type of machine now, where you can use a regular cycle or you can use an installation V.A.C or V.A.C Varaflo. So it consists of two phases. One is installation or dwell phase, where the fluid is put inside, which cleanses the wound. It dilutes and solubilizes infectious material and wound debris. And then there's a vacuum which takes away all that. Remember, in conventional V.A.C or conventional negative therapy, we used to have continuous mode as well as intermittent mode. Here, only continuous mode is used, because that intermittent mode where the wound is, the foam is sucked and removed, may lead to leakage with fluid inside. And there are different types of modes. Several experiments were done on porcine model as well as on humans, and people realized that the granulation tissue thickness is much better with NPWTi, that is installation therapy. Similar comparative trial was conducted, and they realized that the granulation tissue is much better. Question is, how long? What is your dwell phase and what is your suction phase? So what people realize, that generally 6 to 10 minutes of dwell phase where fluid is put inside, and about 3 to 4 hours of suction gives the best results. Normal saline is considered to be quite good. Prontosan or polyhexaminide also is a solution which is often used, and both work as well. So what has been our protocol? We have been, for large foam, we put about 30 ml with medium intensity, 10 minutes of soak time, and 4 hours of suction. When the foam size is medium, about 15 ml. And when the foam size is small, we instill only 6 ml per cycle. Quite useful when there is a late presentation, cavities, and so on and so forth. Prontosan, as I said, works well, but it generally leads to pale granulation tissue. So when you are about to put in a flap or a split thickness graft, that is the time when you change from Prontosan to normal saline. So the last cycle should be saline. Of late, you must have come across that the new foam is introduced, what is V.A.C Varaflo Cleanse. So it consists of 3 foams actually. The innermost one is like a wound contact layer, and it produces, it's a reasonably thin foam and delivers topical solution. Once while it is getting sucked, the solubilization of wound debris is much better, and it produces granulation tissue really well. You can see that's the cleanse foam, that's the standard foam. It is especially useful when the general condition of the patient doesn't allow surgical debridement, especially when you are doing for bedsore dressing. Of course, presence of fibrin, slough, or non-viable tissue is negative pressure therapy with installation is very, very useful. So you can see this is bimalleolar pots with infection. Medial malleolus was in non-union diabetic patient. We just wanted to control the wound and continue in a brace. And you can see the wound, markedly fibrotic wound. You are not really happy with the wound. With negative pressure therapy with installation, such wounds improve very well. Here you can see the wound on the medial malleolus, the multiple cavities initially. The wound has improved significantly. That is where we could do partial closure, same thing on the fibula side, and we could do a flap cover for medial malleolus, a split thickness graft for the lateral malleolus, and with that, we had a extremely good skin cover, and we had decided to manage her in a brace because of her diabetes, and this is where she is at 18 months. Wound has not broken down at all. Lastly, I'll come to a very, very challenging case. A youngish fellow, fall from scooter, sustained injury to right elbow. He noticed that he could not lift his briefcase. The pain increased over next few days. Went to an orthopedic surgeon who realized that there's a small crack radius. So he gave a Scotch cast. Pain increased tremendously at night. The surgeon univalved the plaster. He was so uncomfortable that he changed the surgeon who bivalved the plaster. But still the pain persisted. Fingers became dusky. He had diminished sensations in the fingers. And a working diagnosis of compartment syndrome was made. The surgeon decided to do a release, but realized the counts were very, very high. And then when he opened, he realized there's a big abscess underneath, which was causing compartment syndrome. The surgeon has shared these photographs, and next day, the counts went to 52,000. Appropriate antibiotics were started. At this stage, the surgeon decided to close. And within no time, he developed very severe pain from shoulder to fingers. And an MRI picked up extensive cellulitis and fasciitis from shoulder to forearm. Extensive edematous changes in muscles suggestive of myositis. So he had necrotizing fasciitis and myositis. He presented to us with marked swelling of forearm and arm, anterior chest wall, scrotal and penile edema because of septicemia, significant pain over the chest wall, and a working diagnosis of necrotizing fasciitis and pyomyositis. Now, in these cases, these cleansed foam becomes very, very useful because it is really difficult to do a very aggressive debridement. And this is where we are. This is the wound at presentation. Vascular sheath was exposed, but covered with sheath. So we need to save his life, save his limb, control his infection because it's a large wound and resistant germs. Cover we can have only when there is no infection. And I don't know whether we will be able to have some function. Here you can see during exploration, that's the biceps, that's the necrotic brachialis, that's the necrotic long head of biceps. This is the necrotic medial intermuscular septum. We excised that and we saw the triceps also was necrotic. The deltoid was necrotic. The fascia on the lateral side of arm was necrotic. And that is what we excised. There was fluid underneath pectoralis major and minor. We did not explore there because he had already got a significant blood loss. So that day we did not apply negative pressure therapy. Post-operatively, he was very comfortable. Pain score was just 2. His counts were coming down. And then we felt that the wound is better. So we decided to use cleanse, Varaflo dressing. Now, question is, with such a large wound, he's going to bleed. And question was, what should be the pressure? And as me and Dr. Chandak also agreed, initially the pressure should be low. We also decided to use wound contact layer for covering the vascular bundle, and then we use this cleanse Varaflo dressing. And when it came to starting the machine, I decided to put the pressure at -75. Well, the company person kept on saying, sir, please put -125, please put -125. While we said that it's very easy for you to advise, we have to manage the fluid management. Now, culture was resistant to all except antibiotics. He filled in lot of containers. Obviously, part of it was irrigation fluid, but his pain increased tremendously after that. Pain increased tremendously after that. We again explored him. The wound appeared better, but there was some necrosis of pectoralis minor, which we excised. But what was most funny was we found muscles to be edematous. And generally, we were not happy. Here you can see the brachial radialis had some fluid correction inside, which I drained. But all in all, I was not very happy. Question is, next day when I went, the patient had not slept for the entire night. It was very uncomfortable. Now what do? I suddenly realized that possibly he has become uncomfortable because there is fluid retention inside. Why should he suddenly become uncomfortable? And then I remembered that the company man kept on saying that the pressure should be minus 125. I increased the pressure to minus 125, and within no time, he said, "Sir, I am feeling much better." And then there was never looking back. Here you can see the wound has improved. We have done partial closure. The pain has decreased significantly. Here you can see with V.A.C Varaflo, on cleanse, the wound has improved remarkably. This is when we did partial closure. The wound, again we used V.A.C Varaflo, but next time, we put a split thickness graft. This is at 6 weeks. We could salvage to a large extent, not by just because of my surgery, but because we followed the suggestion of the technician also. So it is important that when you are instilling, the pressure should be as suggested, minus 125. Otherwise, there will be fluid collection inside and there will be severe pain. In case you want the pressure to be less, use standard V.A.C. Don't use V.A.C instill. This is at 4 months, absolutely healed wound. Sorry. This is
another case.
Yes, sorry. Yes. And this is at 4 months. You can see he has already gained about 90 degrees flexion. And the wound has remained absolutely dry. We could salvage all this largely because of group managing this, the ID person, infectious disease specialist, orthopedic surgeons, and of course, the machine, that is negative pressure therapy. Thank you, friends. I'll just wind up. I think we are almost about 5 minutes left.
So
if we have, I think, some time, do we have 5 minutes, Dr.
Yeah, I think
Neeraj?
we can. Yeah, we have time, sir. We have time.
We have 5 minutes. Okay. So I'll present this case just to show that don't be over dependent on any machine. This is a young person presented without any treatment for 4 days. You can see the talus is completely out. He has a peritalar dislocation, open peritalar dislocation, a large wound here. And I decided to do a very aggressive debridement. Of course, looking at the X-ray, you would realize that the talus is going to go necrotic. We just felt that if we can address the wound well, have uninfected area, and then maybe we can do anything. So this is what we did. We reduced everything, put in V.A.C, and the cultures were bad. Pseudomonas, Enterococcus species, Acinetobacter, and fungus. So many antibiotics were started. At 2 weeks, the wound appeared to have good granulation tissue, but there was a bead of pus inside. We were really not happy. And then I thought, let me try negative pressure for some time. Then only I can do a split thickness graft. So patient, so many times patients go home and people keep doing dressings, negative pressure therapy at home. And that is what exactly happened. This bead of pus persisted every dressing. So at about one 1.5 months, I realized that no, there's something wrong. So I got an MRI done. You can see he had a significant collection, osteomyelitis talus, and here you can see the talus is absolutely necrotic. Because day one, the blood supply was lost. Obviously, the talus was to become necrotic. We addressed him at 4 months. He had real bad spectrum. So it is better to compromise early. There is no point in keeping this talus because you can't, whether you use negative pressure therapy, whether you use instill, whether you use cleanse, a dead bone cannot become alive. And an infected area around a dead bone is a great challenge unless you take out that dead bone. So we took out talus. Within no time, the wound healed, started healing. This is at 1 week, we could do a split thickness graft. And this is at 30 months follow-up. He's walking with a stiff foot, with mild equinus, but we could salvage, we could control the infection, and we could salvage his limb. So friends, this is a game changer for the challenging wounds. But remember, don't depend on any machine because it needs to be used appropriately. It is just one wheel of the machine addressing the infection. It helps optimization, but does not replace your knife, appropriate antibiotics, and other methods. And of course, management of comorbidities play a very major role. However, remember, you need to, at the beginning, you need to have proper plan or a roadmap. Why am I using negative pressure therapy? When am I using negative pressure therapy? How am I using it? Which one I am using it? How long I am using it? And as time passes, during your journey, you keep changing your decisions or modifying your decisions. And then if you follow all that, you can use it extremely well, and that would be very, very useful in complex wounds. Thank you, friends. Yeah. You are muted, doctor.
Yeah, thank you very much, sir. A question to you. How do you manage those complex areas like around elbow, around shoulder, axilla to seal those wounds? Any special thing where difficult geometries are there? Or like on a hand or on a foot? Any tips?
So very often, especially on this elbow, in this case, we first applied V.A.C, confirming that we have at least an inch of no sticking material. If it goes round and round, it is very likely that it will constrict.
Right.
So you need to have some space there. Very often we staple the edges.
Right.
We staple the foam to the edges so that it doesn't move. I have found Debrizan and some white, any white ointment that can be applied to the edges of the wound and take a negative of that using a foam. Put the foam over that wound so that you will know the exact shape of the wound. Cut your foam accordingly so that it fits very well. Earlier, what you used to do is try and put the entire foam inside, and it used to overstuff. As you rightly pointed out, overstuffing is not good. We need to slowly start decreasing the size of the wound by using smaller and smaller foam. For that, you need to have a shape of the wound very well. These are some of the tips and tricks.
Right. That was wonderful. And I would just like to share 2 slides about if I can share. Able to see this? Able to see the presentation?
No.
Okay. I'd just like to share how V.A.C installation. There are 2 modes which are available, which can be used, the previous one and the present one. So just 2 slides.
Sure. Please.
There are two. Initially, both the tubings were in the same thing. And so this was one for inflow and one for outflow at the same sites were there. But now
Right.
the recent one, this is a machine where we would keep the solution hanging. The machine itself has a stand, and now there are from different sides. So one is for inflow, the other is for the outflow. So smaller tubing and a bit larger tubing, and then they help us out in installation. So this is how the newer advancements.
Yes.
So
Yes.
how do you choose? How do you choose a simple vac machine or a vac Varaflo or installation? What wounds you would prefer installation? Any tips on that?
If I am generally happy with the wound, number one. Number two, there are not many cavities inside.
Okay.
Number three, the soft tissues per se are reasonably good. If it's a case of pyomyositis or a necrotizing fasciitis, then the debridement often is not really thorough. Very difficult to make out whether you have debrided it properly or not. Under the apparently normal muscle, there could be collections. There could be slough inside, and in that case, I would like to use instill vac.
Okay.
But
Okay.
otherwise, when I'm quite happy with the wound, I will go ahead with the standard vac.
And your most common irrigating fluid is Pontosan or any
No.
antibiotics also you add like
No, I use only saline or Prontosan.
Pontosan. Okay. Thank you.
I'm quite comfortable. What about you? Do you use any antibiotic solution?
No, not yet, but I tried in couple of patients where the sensitivity was for either amikacin, for gentamicin, but I'm not sure how much is going to get into the circulation, whether it is really effective or it is going to lead to resistance. Not sure. So using it sparingly, as you said, mostly I'm using the irrigating fluids one.
So as of now, there is no evidence to suggest that antibiotic solutions would be better than normal saline.
Right.
So I think let's stick to that.
Thank you very much, sir.
Thank you.
Useful tips. And Deepika, if there are any questions, we'll take those questions. And we are towards the end of the program. This was an interesting presentation we saw from Agashe sir. Very challenging, very challenging cases. And really, as we gain more confidence with VAC, everyone in the ward, even in the OT technicians and ward system, everyone is happy if a VAC is put into place, because patients do not keep on complaining about the exudates which are bothering them in the dressings. It has really changed the overall management in the wards.
Correct. There seem to be 2-3 questions there. What?
I think we have taken up those questions.
Actually, we have taken up those questions. Okay, fine. So, Deepika, it's about 5 minutes past the scheduled time. You're there, Deepika?
Yes, sir. So first of all, a big thank you to both of you for a very insightful session today. It was very, very interactive and very good learning. So there is one more question that is there from one of the delegates. The question is, how has been your experience with Varaflo in the infected implants? And basically, what are the installation solutions that you would prefer, especially for the infected implants?
Yes. So, very early intervention. If you try to salvage implant at, say, couple of months, then you are not going to be successful. By then, biofilm has already formed. It is very, very unlikely that negative pressure therapy would help. But if there's a implant which is exposed at, say, 2 weeks, 2.5 weeks, reasonably early in the life, in the cycle of that, and you have a defect with which you can excise quite well, try and get a decent margin, followed by instill therapy, as we discussed, I use only saline. Then I would use this negative pressure therapy, which in my opinion would be quite useful as far as plates are concerned. As regards nails are concerned, it becomes very, very challenging. But as regards plates are concerned, very often you are able to salvage early in the treatment period. And then what is important is what Dr. Chandak showed. He did flaps in every case. He did not try to close. I think Dr. Chandak, if you could just elaborate on that.
Yes. So basically, an implant which is salvaged and there is a tissue defect, we need to cover up with a flap after taking care of infection and putting negative pressure wound therapy, because a good tissue cover is what is very important in all these cases.
Correct.
As in most of your cases also, sir, you have always emphasized on debridement, and then covering the tissue so that a healthy tissue is provided to the bed.
That's it. So consider flap every time when you are trying to salvage an infected implant. Debridement, negative pressure therapy. As of now, no evidence for using antibiotic solutions and a flap. I think these are the four important things, right? Okay, Deepika, I think we have answered that question. Anything else?
Thank you so much, sir, for that answer. One last question, that's for Dr. Chandak. Basically, sir, in terms of the large trauma wounds with a lot of infections, what is the therapy settings you would prefer? I mean, we have already discussed about the pressure settings, like setting in terms of installation volume or the soak time. I mean, how do you prefer?
So in large wounds, initially I would always prefer not to have an installation therapy. I would put up a regular vacuum assisted closure mode or a negative pressure wound therapy with initial pressure at around 50 to 75. And once I'm sure after 12 hours that there is no rapid collection, then I will increase the pressure to 75, 100, 125. If it is a wound is large, around 125 with the maximum amount of the machine, not the mild moderate, but the maximum one. That is what I would use, but I'll take around and the next day I'll change the settings. First day is minimalistic. This is how I would use it.
Right.
But the most important thing is a effective sealing, and the sealants provided with the Varaflo is the installation vac is also very good. Occasionally we do use tincture benzoin at the end of the wound so that it gives enough sticking power to the available adhesives, and they stick very well. And your foams which have provided the film, one number is to be removed first and number 2 is afterwards. So at around the joints we remove the film 2 also, so that we can mold it appropriately to the joint cover, and then it sticks well and then provides adequate pressure sealing. Thank you, Deepika, for that question. And I think it's the time for you to take over and
wind up.
Thank the delegates. Yeah.
Sure, sir. Thank you so much for that answer. Now, just to close the session, once again, a very big thank you to Dr. Vikas Agashe and Dr. Chandak for a very, very insightful session today. Also, special thanks to Dr. Neeraj Bijlani and Dr. Ashok Shyam from OrthoTV for making today's program a seamless one. Last but not the least, I'd like to thank each one of you for taking out time to attend today's masterclass. Thank you, everyone.
Thank you very much. Thank you. Thank you. You can stop recording now. OrthoTV, you can stop live streaming.
And if there are any questions, Deepika, later on also we'll be able to answer them. You can post us on our mail ID, etc. So no issue.
Sure, sir.
Yeah. This being a very interesting topic and lot of questions, and lot of youngsters do have questions. So we'll be happy to answer those questions. You can put through mail or you can put through our WhatsApp. No problem.
Sure, sir. Thanks once again. I mean, it was an amazing session today. Very, very interactive.
Thank you so much.
Thank you.